You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for December 2nd, 2022. We're back after a Thanksgiving holiday, and we're talking SGLT2 inhibitors for chronic kidney disease, publishing choices, second and third order effects of healthcare interventions, decision support, and patient selection for preventive procedures. First up is the SGLT2 inhibitor story. Right before the AHA last month, New England Journal of Medicine published results of the EMPA Kidney trial, and I've failed to cover it until now. This is a big trial. As background, there are two important trials to mention with SGLT2 inhibitor use in patients with CKD. Now recall, cardiology listeners, a lot of our AFib, valvular, and coronary patients have CKD, creatinines 1.4, 1.5. In Credence, the Credence trial, canagliflozin versus placebo, published in 2019, diabetic patients with CKD, a median eGFR of 56 milliliters per minute per 1.73 meters squared of body surface area, and a median urine albumin creatinine ratio of 923, had a statistically significant 30% relative risk reduction in the primary outcome, which was a composite of end-stage kidney disease, doubling of the serum creatinine, or death from renal or cardiovascular causes. Then, 1 year later, the DAPA-CKD trial, published in 2020, found that dapagliflozin in patients with a median eGFR of 43 and a median urinary albumin to creatinine ratio of 965 reduced the primary outcome of sustained decline in GFR of 50% or end-stage kidney disease or death from renal or cardiovascular causes by 39%. Now, this was a very large 5.2% absolute risk reduction, and it was highly statistically significant. DAPA also reduced the composite of cardiovascular death and heart failure hospitalization by a statistically significant 29%. And in DAPA-CKD, a third of patients did not have diabetes. Now, the question was class effect or drug effect. Now, given all the cumulative data on SGLT2 inhibitors, it was highly likely that empagliflozin in CKD patients would also provide benefit, and indeed that is what EMPA Kidney found. This 6,600 plus patients had a mean age of 63 years and CKD with a median GFR of 37 and urinary albumin creatinine ratio of 331, so not as much albumin in the urine. The primary endpoint was progression of CKD, which was defined specifically as either end-stage kidney disease or a sustained decrease of eGFR of less than 10, a sustained decrease in eGFR of greater than 40% from baseline, or death from renal causes, and the other component was CV death. And the results, the trial was terminated early for efficacy, which may be important. The median follow-up 2 years. 13.1% had a primary endpoint in the EMPA group versus 16.9% in the placebo arm. So that 3.8% absolute risk reduction resulted in a 28% relative risk reduction. Confidence intervals on that hazard ratio of 0.72 range from 0.64 to 0.82. Now, the benefit was driven mostly by a reduction in the progression of CKD. Cardiovascular death rates were not significantly reduced. Notably, and I really like this, total hospitalizations were reduced by nearly 5% in absolute terms with empagliflozin, and that is a substantial reduction. There was no heterogeneity of treatment effects based on the subset of CKD as measured by GFR, but there was with the urinary albumin creatinine ratio. Here, the benefit seemed to cluster in patients with a urinary albumin creatinine ratio greater than 300. There was also more benefit in patients with diabetes versus no diabetes. Some comments. EMPA Kidney is what we look for in trials, right? Statistically robust and clinically meaningful effect sizes. Trial was large and it hardly had any dropouts. Taken together with the previous data from Credence and DAPA-CKD, it's very clear that SGLT2 inhibitors have a protective effect on the kidney, which may be greater in patients with more albumin in urine. Now, Lancet recently published a massive meta-analysis on the impact of diabetes on the effects of SGLT2 inhibitors in kidney outcomes, and I'll link to that. The main efficacy outcome of the meta-analysis was kidney disease progression. It was 9 trials, 74,000 patients, and compared with placebo, if you were allocated to the SGLT2 inhibitor group, this reduced the risk of kidney disease progression by 37%, highly statistically significant. And there were similar relative effects in patients with and without diabetes. And in the 4 chronic kidney disease trials, the relative rates were similar irrespective of primary kidney diagnosis. SGLT2 inhibitors reduced the risk of acute kidney injury, the risk of cardiovascular death, or hospitalization for heart failure, again with similar effects in those with and without diabetes. Overall, I think this meta-analysis seals the deals on the question of diabetes, and that is, it doesn't really matter. The drugs reduce the risk of renal progression in patients with CKD, regardless of whether they have diabetes or not. Okay, second topic, publishing choices. JAMA Internal Medicine published an observational study that found an association between organ donation and motorcycle rallies. Now, guess what the results were? Organ donation increased during motorcycle rallies. I don't understand this. Now, shall we study boating accidents around July 4th, heat illness, or drownings during the summer months, or the incidence of depression during the lockdowns? I don't understand why researchers would spend time on something so obvious. Why would a journal not only publish it, but also attach an editorial to it? And I think I know the reason, and I'll tell you why. 58 news outlets picked up this story. It's already in the top 5% of research by Altmetric. Now, I mean no ill will to the journal or the authors, but what these sorts of papers do is highlight the business model of scientific publishing, which is attention, page views, etc. And it's the same really for medical journalism. I wished it were not so. But here I place less blame on the journalism industry because they are tasked with reporting what's in the journal, so it's the upstream journal decisions. And this story makes the podcast because understanding what gets in journals is an important meta theme in critical appraisal. So whenever you read a paper like this, think what paper did not get in because of papers like this. All right, second and third order effects of treatments is the third topic today. Journalist Marlene Busco, who has an eye for important papers that are often off the main stage at meetings, reports on a very important paper abstract presented at the American Heart Association. Dr. Rebecca Woodruff, an epidemiologist at CDC, presented a paper at HA that found a spike in deaths due to heart disease during 2020, the first year of the pandemic. Now, this is notable for 2 reasons. One is that there had been this beautiful, steady, year-over-year decline since 2015 of heart disease deaths. Second reason it's notable is there was a greater increase in cardiovascular death in young, non-Hispanic Black patients. Now, she noted, and I'll quote, non-Hispanic Black patients and younger adults may have had more exposure to COVID at their workplace, less financial stability, greater stress, and more limited access to health care. So, my friends, let's stop and think here. Why exactly do you think non-Hispanic, Black people, and younger adults had less financial stability, greater stress, and more limited access to health care in 2020? Now, ponder that question while I tell you the rest of this story. Another expert that Marlene Busco quoted said, quote, "Clearly the findings of this important study should serve as a wake-up call since we slid back many years of progress." All right, some comments. When doctors decide to intervene, there are first-order effects. If you order a coronary calcium scan, a first-order effect is finding the presence or absence of calcification. When we decide, for instance, to recommend early AFib ablation, a first-order effect are the isolation of PVs or the presence or absence of a complication from the procedure. But of course, that's not all. There are other downstream effects. I'll call these second and third-order effects. For example, when you order a coronary artery calcium scan and it detects a hunk of calcium in the LAD, you've now created a patient who was once a well person. Now, that person may now think twice about vigorous exercise. When you promote widespread CAC screening to the population, you can create a society or cultural feeling of healthism, as in, you should do this test or you're an irresponsible person. It creates this societal sense that we can control our life and death. Now, my point isn't that these are bad or good things. I do have feelings about it. But my point is that interventions have second and third order effects. Now, it's the same with AFib ablation. A second order effect of recommending early AFib ablation is the creation of this idea in the patient, a false idea that AFib is a focal disease like SVT that is amenable to a procedure rather than lifestyle modification. That person may now tell his friends or post something on an AFib patient internet forum. Then when we as a profession promote early AFib ablation, we risk creating a false sense in society that AFib can be treated with a catheter rather than healthy living choices. All right, now go back to 2020. The COVID virus was terrible. It was bad. I know that. I'm not minimizing it. And the first order effect of shutting down the world was to minimize spread of one pathogen. But 2 years on, Dr. Woodruff from the CDC now tells us about second and third order effects, which when some people tried to mention during 2020, especially the part about increasing disparities of care, these voices that expressed these worries about second and third order effects were, let's just say, were not encouraged. I hope the medical establishment does sort of a M&M and learns from the many lessons of the pandemic. And one is surely that healthcare and healthcare decisions are complex. And it's really important to think beyond simple first-order effects. All right, next topic is a topic dear to my heart, and that's decision support. At AHA, Paul Wang from Stanford University presented the results of the ENHANCE AF trial. The journal, the American Heart Association, published this trial. Now, I like the idea of this paper because it studied in RCT form the use of a decision aid for anticoagulation decisions in patients with AF. And if you think about it, anticoagulation decisions are weird. On the one hand, they're one of the most common things a cardiologist or even internal medicine clinician does. And on the surface, the decision seems like banal, just take the anticoagulant or not. But on the other hand, when you get into it, when you get into this decision, it gets hugely complicated right quick. To start with, we use the CHA2DS2-VASc score, a simple integer score, which may be fast and frugal, but it gives us a severe false sense of knowledge. For instance, there's no left atrial data in the CHA2DS2-VASc score, and permanent AFib is considered the same as low-burden AFib. It boggles my mind that in an era where rockets can go into space and then land safely, doctors use an integer score to make anticoagulation decisions. Now, another issue is this. Even if the 2.2% annual stroke risk is even close for patients with CHA2DS2-VASc 2 or 3.3% for CHA2DS2-VASc 3, what does that really mean? I mean, how do you versus your partner internalize that? How do patients understand that? I'm asking, I don't know. And what about the issue of pill disutility? I mean, how often do we think about the implications of taking a pill every day, forever, one that doesn't make you feel any different? These are the questions why I'm so drawn to decision support in these kinds of situations. Now, Wang and colleagues used a very basic digital support tool. I looked at it. It's a brief 4-minute video, some basic facts, a worksheet, 3 easy questions, and then a worksheet with a list of questions to bring to the clinician. Now, the clinician also has an app, and more on that in a moment. Now, patients with AFib were randomized to the support tool or usual care. The primary endpoint was decisional conflict. Now, you don't hear much about this kind of endpoint. Decisional conflict is sort of a state of uncertainty about a course of action. And the uncertainty can be about a lot of different things, like patients confronted with decisions that involve risk or uncertainty, when high-stakes choices that have big gains or losses are entertained, or when there's a need to make value trade-offs in selecting a course of action, or even when there's anticipated regret. Now, this decisional conflict is measured on a validated 16-item decisional conflict scale, and the results of the enhanced AFib trial were clear. This trial had 1,000 participants that were enrolled and followed at 5 different sites in the U.S., and there was a clinically meaningful reduction in decisional conflict, a 7-point difference in median scores in the decision support arm. This was not a clinical outcome study, but there were no differences in stroke or bleeding outcomes in the 2 groups, and most interesting was the fact that reducing decisional conflict did not alter anticoagulation acceptance. Equal numbers of patients in each arm accepted anticoagulation, and that might be a little different from some previous studies that have found as decision quality increases, acceptance of warfarin may decrease. On my comments, I highlight this study because it gets close to empirically studying decisions. And I want to highlight the notion of second-order effects. Again, the first-order effect of oral anticoagulation is providing a net benefit in stroke reduction. Measuring outcomes like decisional conflict, however, underscore the idea that a second-order effect of anticoagulation recommendations may be to improve patient education. And if that's done on a wide scale, improve societal education, which is sort of a third-order effect. My friends, not every endpoint in cardiology need be a clinical endpoint. Reducing decisional conflict and decisional regret is a huge thing. I've often wondered if an ICD quality measure ought to be decision quality. Measure what patients know about their device. Now, this is important because cardiology is replete with preference-sensitive decisions that turn on patient education and partnership with a skilled physician. The ideal situation, remember, is that patients take the most effective therapy that also aligns with their preferences. Okay, 2 criticisms of the paper. One is the decision support tool. Now, specifically the icon array graphic, which depicts the number of people with and without a stroke. You've seen these huge plots. They're really helpful for patients to see absolute risks and risk reduction. And they were only available in the clinician app. I think these need to be in the patient app so patients can actually appreciate the effect size. The second criticism is that this looks more like an education intervention that increased patients' confidence in their medicine. Table 1 shows that over half of the patients were already on anticoagulation, so they didn't really target people who were in the throes of decision-making. That's kind of an important distinction because this may be more of a good intervention for helping patients be comfortable with their anticoagulation, but it may not really be a, quote, shared decision-making tool, as it isn't clear how it actually influenced the decision. Still, though, we need more studies like this. Decision quality is a really important metric, and so is empirical testing of ways to get there. All right, final topic is left atrial appendage closure percutaneously. And no, don't stop listening. I'm not going to talk about the seminal trials again. I'm going to talk about something different. I want to highlight a disturbing trend in real-world application of this preventive procedure. A new paper is out with sobering findings regarding patient selection and outcomes. Now, this paper is in a journal you might not normally read. It's in the Journal of Clinical Medicine. The first author is Ziad Anow, and he led a group from Israel who used a national Israeli EHR database of patients with AFib who had appendage closure from 2016 to June 2021, so a contemporary sample. The primary outcomes they were interested in were hemorrhagic and ischemic stroke, but they also looked at bleeding. Sample size was a little under 400 patients, and their follow-up was short at 2 years. Now, before I tell you the results, stop and think and just guess what you think the ischemic and hemorrhagic stroke rates were in this real-world sample. And as a hint, I will tell you what they were in the device arm of PROTECT, PREVAIL, and PROG 17. For ischemic strokes, in PROTECT, stroke rates were 1.4%, PREVAIL it was 1.9%, and PROG it was 4.4%. Now for hemorrhagic stroke, rates in PROTECT were 0.2, 0.4% and weren't reported in PROG. Now in this observational study in Israel, ischemic stroke occurred in 13% of patients and hemorrhagic stroke in 4.4% of patients. Israeli paper also reported a GI bleed rate of 8%, which was higher than PROTECT and PREVAIL. Now, one possible explanation for this was shown in their table 2, was that the mean age of patients in this real-world Israel experience was 77 years, and the mean CHA2DS2-VASc is 5.5, both of which are way older and way sicker than those enrolled in the seminal trials. Now, my comments here are that the paper pairs well with a recent paper I reported on September 17th, TWIC podcast. This was also an observational study of about 800 patients from Spain, Italy, and Canada published in JACC EP, and that paper found that 1 in 6 or 15.5% of patients in that series died within the first year, and of course, if you die within the first year of a percutaneous appendage closure, you're really not living long enough to get any benefit. Looks like we're doing the same thing here in the U.S. real-world population. I was part of an abstract that looked at Medicare claims data and found that the average age of patients who were having appendage closure was 78. Of course, similar to the Israel data I just told you about. And we also found that there were higher rates of comorbid conditions when compared with the PROTECT and PREVAIL seminal trials. And the most recent NCDR paper from the Watchman investigators published in Circ Outcomes, first author of this paper was Usama Daimi, also found that the mean age of Watchman implants in the U.S. NCDR data is 76 years and the mean CHA2DS2-VASc is 4.8, which is also higher than the seminal trials. So the simple thing here is no matter how you feel about percutaneous closure, even if you're a proponent, the use of this device in older patients with greater comorbidities is worrisome. That's because older patients will have a higher procedural risk, so more upfront risk right there. They'll have more competing causes of stroke from, say, vascular disease, and they're going to have higher risks of bleeding from antiplatelet agents. So the answer, the obvious answer, is you randomize these patients, then we would know. And I don't understand why we don't do that, but we don't, so we don't know. But I do worry about using this procedure in higher risk patients. We just don't have an answer about whether it's beneficial. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And over the holidays, I noticed a lot more reviews and ratings, and I really appreciate that. Again, take the time, give us a rating, write us even a 1 or 2 sentence review. These things go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.